Scott County, providing safe, healthy, and livable communities.
Take it away. Wow, yes, it is.
This is a really strong Scott County delivers, and I don't know how we follow either of
That's-
those first two agenda items.
That's a tall task.
So we're just really happy to be here today. We are here today to talk about emergency mental health and emergency and crisis mental health services. We have a varied group of professionals here to talk with you this afternoon. Really excited to drill down into some of the things we've been working on for some time. I'd like the facilitators to introduce themselves and where you work. And then Dr. Martin, if you could just do an introduction of who you are, and we'll just go down the table and then we'll get started.
Tony Winnicky, I'm the county highway engineer.
Jennifer Schultz, Scott County Library Director.
Jake Grusing, Transformation Enterprise Services Director.
I'm Dr. Erin Martin. I'm the Clinical Director of the Scott County Mental Health Center.
Jody Kaiser-Kisting, I'm an Assistant County Attorney.
Jeff Tate, Shakopee Police Chief.
Amber Barnes, Supervisor with Adult Mental Health.
Caleb Madden, Scott County Sheriff's Office, Assistant Jail Administrator.
Hi there, I'm Dr. Tanya Ward. I'm the Director of Behavioral Health and Housing. And I think I'm last to introduce myself, so can I quickly give a thank you to the folks who helped prepare this. So I really want to thank, I don't know if Mohammed's here. Oh, there you are. I want to thank Mohammed. We went back and forth many times with this data, and he put in a lot of hours. So I just want to, give a shout out to him. It was a lot of work, and I also want to thank Evan and Chris. They have seen a lot of me doing this data, so thank you to both of you, and thank you.
Thank you. Thank you for kind words. Could we go first to page 7, and then Jacob, if you would take the first question. I just want to point out that one of the community indicators that we look at is the availability of mental health services in our community, and this is data that has come before the board many times. Essentially, what this chart shows is the ratio between mental health providers and our population. And what it says in summary is that we have a growing number of mental health professionals available in our community, and that we have a generally on trend a decreasing percentage of those mental health professionals who are county employees. So why that is important is that we really want to build out this continuum of mental health services, and that's quite a lot of what we're going to talk about today. And so I just wanted to point out, this is really the piece that we're trying to impact, is making sure people have access, not only through the county, but through community resources to mental health services that they need.
Thank you. I was worried you were going to take my question because I was going to bring us to page 7 and talk about the community indicator. So nice introduction. So for this community indicator, it's interesting to see what looks like improvement in the number of mental health professionals in the community. And I was just at a high level, what does this say to you from your perspective relative to the topic today for emergency and crisis mental health? What is the connection between what we're here to talk about and this higher level indicator of there are more mental health professionals in the community?
I'm sorry, I'm struggling to, my eyes are hard to see. Well, I think, as we're seeing the growth, there is a growth in the mental health profession, as we're seeing, but our population is also growing. I think as we'll see, I like this measure because it does look at the proportion that we have. And if this could, and I'm not saying to do this, if this could be dissected more, because there are folks who do outpatient work, and then there are professionals that do more of that intensive service. And I think that's where we're seeing the shortage, is that intensity. And so that's really the link, I think, between the ones we're going to be speaking about today, is really that like middle inpatient, right below inpatient, those providers. That's where I'm seeing mostly the shortage. I don't know if anyone else wants to chime in on that.
Yeah, I would agree with that. I think although there is a growth in mental health providers, I think the growth in need for mental health services has surpassed that. So I think we're moving in the right direction in terms of the support that we can provide, but definitely a good point from Dr. Ward about the services that are needed. There seems to be a gap there as well, the crisis services and the stabilization supports. Yeah.
Okay, so maybe we can look at pages 7 and 8. I'm sorry, 8 and 9. We just looked at 7. Pre-petition screenings and then repeat pre-petition screenings. Looking at the data in 22 and 23 and partial data in 2024, looks like we're trending up in both pre-petition screenings as well as then repeat pre-petition screenings. I'm wondering if somebody can talk about thoughts around what's influencing that, and just how you're addressing that seemingly increase in those pre-petition screenings.
Yeah. So I would say we're post-COVID, which I think is how the world is referring it. We're in a post-COVID time period, and I think right now we're still kind of seeing the aftermath of that. During the couple of years of COVID, individuals were, of course, forced to isolate. Everything moved to virtual, and I think research has shown that in-person care is probably the best service delivery. So right now with pre-petition screenings, we've seen an uptick. Of course, to give background, a pre-petition screening is like on the most extreme end of mental health. That's when someone's ordered by a court to be civilly committed, and they're court ordered to take medications, go to appointments, things of that nature. So we don't want to civilly commit people, but I think just the acuity of mental health that we're seeing just continues to rise. In addition, I think thinking of my coordinator response team, we are and have been engaging individuals in the community who historically haven't engaged before in services. And so unfortunately, because they are so ill and have been for some of them at times 10 plus years, we do need to go down that intense road in order to get them stabilized. So I think that's kind of why we're seeing an uptick, including we're seeing an uptick of Rule 20s, and I'm looking at Jody from the county attorney's office. So I don't know if you have any insight into why we're seeing that uptick.
We're seeing that in criminal cases when an individual is determined to be incompetent to proceed on their criminal charges. Then under the rules of criminal procedure, we're mandated to do a pre-petition screening. So we've had a very steady number of criminal cases, but we're seeing an increase in the number of individuals found incompetent. So that's accounting for some of the uptick. I think another reason that accounts for it is that people are more aware now that there are services in the community. So they're accessing those services, and I think that's an excellent result of why we're seeing an uptick, is because people want those services, and word is spreading in a positive manner, I believe.
Amber, do you think that's different at all for the repeat petition screenings? Is there anything that changes that for on those repeat ones?
I don't think so. I think my answer would probably be the same for the repeat. I think there's a small population of clients that we serve in adult mental health that are always going to be reflected on this repeat number, essentially meaning they get civilly committed and stabilized for a period of 6 months. The commitment ends, and then they have their rights back, meaning they have the option to choose not to take medications or engage in services. So we're just seeing that continuous cycle. And unfortunately, I think there is a small population of that is just probably going to be for the entire length of their lifespan.
Thank you.
Go ahead, Tony. I had two questions. One, Jody, part of the narrative suggested this increase in the number of Rule 20s that are being requested by defense attorneys. Do you have concern about the legitimacy of those requests?
I think one thing that is important to remember is that the defense attorney develops a relationship with their client, and so they have the opportunity to converse with them in private and have multiple interactions with them. And they're the first level of opportunity to determine whether or not someone is really engaged in what's happening and understanding it. So I know that my colleagues in the defense bar take their jobs very seriously, and I believe that they are making those requests for Rule 20 evaluations based on their direct observations and interactions with their client.
Okay. Thank you. And then my other follow-up question to that was, when you, and I'm not sure who to direct this question to, but we've made a lot of investments in mental health services across the continuum, have plans for a brand new behavioral health center, like we're continuing to build this out. And so what does it say to you as you see this continued increase in the number of pre-petition screenings weighs against those investments?
I'm glad you asked that, because I was thinking the same thing. Going back to the percentage of repeat screening, that's where I hope we will see a decrease in that number. Because with what Jody said, I think folks, concerned family members know that there are mental health resources. And so we are seeing an increase in the screening requests, either from hospitals, it's mostly from hospitals, but the folks who bring their loved ones to the hospitals are their family members. So I think we will see the increase in screenings, but I'm hoping that the percentage of repeat goes down because they are linked to services in the community and they feel that those are helpful.
Thank you.
Could I just add on what Dr. Ward was saying? I too would think that our instances of repeated screenings would be decreased, because when an individual is screened, the case isn't automatically supported. And when we determine that a case should not go forward, it's usually because someone is willing to engage in voluntary services. And so the idea would be that if we have additional resources within the community, they could then get connected to those resources on a voluntary basis, and hopefully that would eliminate the need for future court intervention.
Thank you.
Can I just ask a follow-up question? It's actually on 10. It talks about the average screening hours. So pre-petition screenings going up, we're spending less time. Can somebody talk about that, or at least it looks like, and again, so the reason behind that, are we getting better at them, or do we have more skilled people? Like how does that work?
Yeah, so I think this could be interpreted a couple different ways. One, yes, I do think we are potentially getting faster at them, but I also think the hospitals are giving us less time to complete the screenings. So typically, in the most ideal world, we would have 72 hours to complete a pre-petition screening. I personally have done one in 4 hours, which is not ideal. It's probably not the most thorough, but that was the amount of time allotted that the hospital gave us before the 72-hour hold was up. So I think hospitals are really working to try and engage the person to engage in voluntary services. So yes, they place a hold right away when the individual gets to the emergency room, but within that 72-hour window, they're really trying to engage them and see if the hold can be essentially discontinued. But I think once they get to that point of, okay, there's maybe 8 hours left on it, they have to make a decision of filing a petition or not. So I think both things can be true.
And I think the hospitals are getting quicker at sending documentation. So that's a big part of the screening process, is reviewing all the medical records. And so as they are seeing more petition screenings, now they probably have a process to get those records over quicker to the screeners, which then helps with getting the screening done in a more timely fashion.
Does it have it all from your guys' perspective, like just moving people through, so that because there's not enough space and beds and they need to move, like make decisions and move people through? Is there any risk that you guys see in that?
I think there's some safeguards built in within the law. The statute mandates that within 12 hours of a patient being brought in on a transport hold, that they have to be evaluated by a physician or a medical personnel. The statute defines what it is. And so at that mark in the process, what happens is they're either determined to be someone that could be released, or they may need to be admitted to the hospital. They may be able to be admitted voluntarily, and if not, then they are placed typically on a 72-hour hold. So that's a safeguard for folks.
On page 14, can you talk a little bit about this and what this is showing from activities and trends here? There's way less clients served in the crisis facility, and just kind of talk about those activities.
Yeah, so at our Savage IRTs that we heard mentioned earlier today, there's two classifications in terms of services there. So one is called the IRTs, and then one is also called a crisis bed. So they are physically located at the same building. The crisis portion requires a higher staff to client ratio. And as we have probably seen in other data, that's been a struggle with getting that staffed. And so they have not had the capacity to take those clients that require a crisis bed. So that's why you see the decrease there.
Dr. Ward, is there work underway to address that?
Yes, we have been meeting, well, they have new leadership, and we've been meeting with them fairly regularly to express our concerns and our thoughts and partner and offer ways to collaborate. We go through every case. If they don't take a client, we ask for why, so we can troubleshoot if there's something we could do to help them maybe accept a client. So it's an ongoing process, something that we're working on. And we continue to help them. They're also looking at, from a staffing perspective, they're looking at market value, market salaries. How do they attract and recruit more clinicians? I know they're looking at perhaps starting a clinical trainee program, which a lot of clinics and providers are needing to do that. That's how we are getting our staff these days. At the mental health center, that's one recruitment tool we're using. To get staff is to start them as clinical trainees and give them supervision hours, so then they get licensed and hopefully they stay.
Nice.
Can we go back to slide 11 for a second? So what does it mean that, to the folks at the table, what does it mean that the percentage of supported screenings is going down and the non-supported is going up? Is that do we draw a conclusion that that's good, or that's bad, or that's just kind of interesting? We don't want to make a value judgment on that?
Yeah, so I would interpret it as good. We don't obviously want to have to civilly commit people. So typically if we're going to non-support a case, it's because the individual is willing to engage voluntarily, whether that be with case management, outpatient services, remain in the hospital voluntarily. So it's definitely a good thing that the supports are going down.
And if we look at the Rule 20 referral process, the threshold to be incompetent to stand trial is a lot lower than commitment. So if every person who is incompetent to stand trial needs to have a pre-petition screening, that doesn't automatically mean that they meet the threshold for support. So if we see an increase, we may not always see the proportionate support to match that.
Where are those when people are in that sort of in between, they've been deemed incompetent to stand trial, but they're going through that process? Where are they physically?
It can vary. Sometimes they're in a correctional setting. Sometimes they're out in the community. Sometimes they're actually also in a treatment facility. What
is the impact on like a jail, for instance? If we have those folks in the jail who are in that in between, what's the impact on providing what you might think of as traditional jail services? That seems like something beyond what a jail typically does. So what's the impact on your work, Caleb?
Sure, we certainly have had to adjust as our traditional jail services change. We've been really fortunate that we feel very supported by the other parts of the county, and the mental health center is a great example of that. Being able to really come to our aid, where we're doing the best we can in meeting folks where they're at when they come in the door. But sometimes we need resources, expertise, and in speaking with my colleagues across the state or across the nation, I feel very grateful to be where we're at. I feel very supported by what we have for those resources. It is a challenge for our staff. It's a challenge for people that are incarcerated, and it's a real issue.
And on a statewide level, DHS is establishing a forensic navigator program. So to help individuals who are in that in-between, whether it be they have sites around the state that are certified as competency restoration states or sites to help with folks get med management or to help with education. Most people who are not competent to stand trial, medication is really the primary intervention that will help them. There's a small fraction where it's due to maybe lower cognitive ability, where you can do some type of education to restore them to competency. And that's where we will see that at those community sites that DHS is working on establishing an infrastructure and a payment and a network system for that.
Can I ask one more question about that follow-up? With just Chief Tate, from your perspective, when folks are in the community, then is there an impact that you see at your local law enforcement level?
Well, our number one call for service in terms of a medical is someone in mental health crisis. So I think we had just 811 in 2023 were just someone in crisis, someone experiencing a need for mental health services. That doesn't include someone who, a call where someone may be facing addiction issues and mental health, homelessness, those types of things that we all know overlap. But yes, it is our number one call that our folks go on is a mental health call.
Chief Tate, do you have any sense about how the coordinated response program, like what that might have saved you in officer time?
Yes, I've got a couple cases teed up here for that question. I've been very passionate about the coordinated response program, and it's something I've kind of been asking for a few years now. I threw out the 2023 number there. I have one individual in our department, in our city, we responded to 85 calls in 2023 for that individual. Okay, all mental health related, 85.
To the same person?
Same person, okay? 2024 year to date, after getting our coordinated responder to work with that individual, get the proper treatment and services that individual needed. Year to date, we've had 4 calls for service. We've gone from 85 to 4. That's a bigger example. Just recently, even here in October, kind of bleeding into November, we had one individual going through crisis, 27 calls for service. We know that the coordinated responder is not going to be able to fix it just like that.
Right.
27 calls for service, and until he was able to get that individual, again, the proper treatment services they needed. Since that happened and that person's gotten those treatments, we have had 0 calls for service. So the impact is profound. Our officers are hooked. They believe in this program and the partnership that we have with the county and the services on this. It is absolutely, I think, an essential program moving forward. So the impact on our time, again, I'm throwing 23 numbers at you here. We had close to, if you count transport holds and voluntary holds that our officers put on people in the city of Shakopee in 2023, was 358. Talking a hold a day. And for those, every mental health call, we really scrubbed our numbers in 2023. The average number of officers responding to a mental health call was 2.34. I wrote it down. 2.3 officers per call. And there's reasons for that. That our training, is indicated and best practices that we try to follow. So when you look at that, the amount of time, the amount of officers that we're spending, if we can go from 85 to 4 or 27 to 0, that is incredible. And that's something we need to keep feeding and keep improving on and working forward on.
Nice. Thank you for digging out that data. That's great. Thanks.
I'd like to just shift a little bit to slides 16, 17, and 18. So I have a couple of questions related to our crisis, mental health services and mobile crisis. First to Chief Tate and Caleb, it looks like a fairly significant decrease in the use of Canvas Health from both the jail and the law enforcement over the last few years. I wonder if both of you could kind of just talk about that a little bit. If, did we make a decision to not use them anymore, or is there something else that we're seeing? Is the data not really showing the true story? What's kind of just as interesting?
We just talked this morning. We had our Scott County and Carver together, our chiefs and sheriffs monthly meeting, and Canvas Health came up, and I walked in halfway through the conversation, so I might have missed something, but I saw a lot of eyeballs rolling and head shaking. I don't think line staff, supervisory staff have a lot of faith in Canvas, and our officers see a better outlet towards our coordinated responders than getting something than the response that they've historically gotten from Canvas Health. So there is, I think, a universal in the county feeling that we're not getting a lot out of Canvas Health. And if they don't hear successes, if they don't see it, if they're not coming out to scenes, they're going to put it on the shelf and not use it. So.
I think from the jail's perspective, we've just had tremendous support from our mental health resources here in the county. It's been really impressive, not just in timeliness of getting there, but in providing a service that's valuable. We have open communication channels in multiple areas of the mental health center where we're talking with them about what our needs are, what incarcerated persons' needs are, as well as an evaluator coming over. We also, with the jail social worker being embedded in the jail, that's made a huge difference in just making those connections and ensuring that stays very solid. I feel very good about the mental health care people are getting in jail right now with Scott County Mental Health taking care of that.
Nice.
So just maybe a follow-up, and I'm not sure if this maybe is Dr. Ward or Dr. Martin, but mobile crisis response is like a mandated service, right? Like we have to provide that. So we've contracted for a number of years. So how do you, looking at the data, how do you start to measure what the return on investment is related to that service and how we continue to think about that? Do you have thoughts about that?
Mm-hmm. Yeah, I help support that contract and work with Canvas. It's in terms of staffing teams, mobile crisis is one of the most difficult. Asking providers to go into a community, most likely a home environment, not knowing what they're stepping into. And so I think staffing is a challenge. And when you have staffing challenges, you have turnover. And when you have turnover, you may not have the most effective or integrated care. And so I think that's inherently something that all mobile crisis teams are dealing with across the state. In our conversations with Canvas, they promote a lot of their stabilization services. And so I look at, so when I'm kind of looking at how, return on investment, I really look at maybe more page 17 and that data, how many assessments are they doing? How many stabilization visits are they doing? Because, stabilization is what keeps people out of the hospital. So in we receive 4 quarterly reports. So those are the things that we're looking at. The jail and then the police department referrals, the decrease, those make a lot of sense to me, especially now that we have embedded, social workers in those departments. And looking at the data historically, Savage was one of Canvas's highest police department referrals, and that also happens to be where one of our coordinated responders is. So that makes sense that way when I take a peek at that.
I would say too, just in terms of continuity of care, the Canvas crisis team works with the clients that we see at the mental health center as well, and we have open communication, and so we're able to work with one another. So if something happens in an evening or a weekend or a holiday or something, they work with, the crisis responders can work with the ongoing therapist, which I think is really helpful and beneficial for the clients.
And this is a statutorily mandated service for us to provide, is that right?
Mm-hmm.
Page 22. Can you talk a little bit about the correlation between the two, between the referred and those that are served? And there's a percentage there, but is there, obviously if it's either, if there's over referrals or under referrals, that changes that, but is there some sort of benchmark, or what is this kind of telling us?
I'm not sure we've set an internal benchmark. We might want to do that. We've been so excited with the data. I'm not sure we've thought about that. It's pretty much at every meeting I've been at, I've spoke about this. It's called a conversion rate when you think about in the world of mobile community services. You receive a referral, which we love referrals, right? Because that's a good measure of our partnerships. So if our referrals were to go down from police departments, we'd want to look at that. Are we really seeing a decrease in mental health, or are we experiencing maybe not so much faith from our community partners? Obviously, that's not the case. I think we all see how this program is going well. But the served, I think, is a reflection of two things, and Amber, jump in if you want. I know I'm talking a lot. Okay, so it's a reflection, I think, of a couple things. So one, I think that our officers in our police departments do an excellent job of explaining the service to the individuals when they're out at their home or wherever they're seeing them. And then I also think that when the coordinated responder is able to make contact with them, I think they do it in a very client-centered and empathic way that individuals then allow them to enter their lives, which probably is at one of the scariest moments in their lives in terms of they just had a visit from a police officer. And so perhaps, things aren't going great in their life, but they are welcoming somebody into it. And when you look at any type of benchmark in terms of getting, I would say like maybe cold referrals, anything above 30% is amazing. And we're at 74. So that's pretty, it really is a testament, I think, to the partnership.
Great, thanks.
I'm wondering about, so you're in the second year of the full second year of the coordinated response program. As you have looked at this, what have you learned things that have changed how you deliver the service as time goes on?
So the one thing I've learned, and I think it was something I didn't even really kind of think about, but when we thought about coordinated response versus co-response, where co-response is a social worker, is paired with an officer going out and in-progress calls. I think Scott County is best served with coordinated response, so I'm really happy that's the model we chose to go with. It really does seem to fit kind of the culture. But Savage specifically, we have seen a shift where co-response is actually maybe more appropriate. And I don't really know why that is, but it does seem like Savage grabs or maybe invites their coordinated responder with for more in-progress calls.
Okay.
So they hop in the squad and go out on a live call. I'm trying to think of other things that.
And how does that land for you? Like, is that a positive aspect, or? Yeah.
Yeah, I think it gets clients access to services quicker, so that's great. But also, not everyone is in that space who want services immediately, right? So I think having the crisis calm down, law enforcement can leave, and the individual gets a night to sleep and reset, and then my team goes out the next day. I think that's also appropriate.
Okay.
So.
Okay. Thank you.
This might speak to your question a little bit too. It's hard to measure, but just the fact that the person is officed in our police department, those informal conversations, those conversations with officers, well, you could have done this, or if this happens again, I never knew that service was available. So when it's Saturday night and you're not working, this is an option I can use when I'm on the road with that person. So I think that's just been invaluable. Yeah. It's been really important. It's made our officers, rising tide lifts all boats. It's really, I think, been again, hard to measure, but you can feel it, you can see it, and it's improved our overall service delivery.
Nice.
And I want to commend law enforcement for allowing us to come into their departments as, just kind of like the odd person out, right? I think they really just welcomed us, and it's really such a family environment now at a point where, the coordinator response, they're on hockey leagues together with the officers that, they're invited to Christmas parties and things like that. So it's really been such a great connection that I wasn't expecting it to go that deep. So great.
Amber, on page 19, the data there seems to me like Savage is almost double what Shakopee and the sheriff's office are together. Do you have any thoughts about that? Why that is, or is that just just look into if you have any thoughts about that that difference.
Yeah, so I would say one thing we've kind of looked at is what's an appropriate referral and what's not an appropriate referral. And I think historically, Savage really utilized Canvas Health more than any other agency. And so when that switch made for the embedded person to come in, some of the referrals we get from officers from Savage aren't necessarily appropriate, or there's different resources that we could connect them to. So I think that's some of it. Yeah, I don't know if we've really put a finger on exactly why.
They just refer more people than we do. We're going to concentrate hopefully on that 80, especially initially. Yeah. We had a list. Here's the 7 or 8 people in Shakopee that we are just frequently getting called to, and those are the most complex and frankly hardest to situations to solve. So we really tried to focus on the bigger calls for service, bigger issues that we've had in our community. Focus on that person that's 85 calls a year, and I think that's just kind of how we shape things.
So maybe just some philosophical differences between the departments. Absolutely. As well.
Yep.
Yeah. I mean, I think, of course, we highlighted her earlier in the day, but of course, Mayor Williams has been a pillar in the mental health community in Savage, which I think trickles down to the chief, city council, officers. So I think that speaks to some of it too.
Thank you.
We go to page 4. Yep. So yeah, this I find a very helpful graphic that shows the mental health service continuum from less intensive to more intensive. And as we've been sitting here talking, just hearing like crisis stabilization, emergency response can feel like, I mean, the words say it, like it's a response to something, it's a reaction, it's an intervention. It doesn't necessarily feel like a preventative measure. But as I look at this continuum and read through the narrative in particular, and page 3, when we start talking about what happens when folks get to AMRTC, to what and I didn't see it like specifically called out, so I'm just going to ask the question. My inference is a lot of this work that we've talked about with emergency and crisis response is prevention work, is preventing folks from moving into some of those deeper end services. Is that accurate? And then how so? How do you see those two things being connected? The work we're doing and keeping folks out of those deeper end services.
I can take this. Yes, I hear what you're saying, and when I think somebody has a visit from one of our mobile crisis responders, I don't see that. I do see that as prevention, and I see that as actually an entry point, because then they are identified as having a mental health concern if they're not already identified as someone who struggles with some type of mental illness. But usually it's an access point, and then they are connected with ongoing services. So they actually might go down the continuum, or In terms, if they go down the continuum, they have a diagnostic assessment, they actually then might go up 2 steps to partial hospitalization or day treatment or any of those. So folks can move up and down on this continuum in a matter of weeks. And I don't necessarily, I don't see that as a reflection of like that the step maybe below wasn't doing good enough. That's how the system is supposed to work. People are supposed to be able to go up and down with our overall goal of keeping people out of probably that last one all the way to the right. Did that answer your question?
Yeah, that's good. Can we go to page 3 while we're in this narrative? With just some of the graphs that were included here and not in the data in the back end. I see in the 3rd column here, there are costs to the county if clients meet criteria and their percentages, and then there are costs to the county if clients do not meet medical criteria. If folks don't meet medical criteria to be in those facilities, does that mean they're no longer in those facilities, or do they stay and we get to pay? And to what extent are we a party to any of those decisions?
Yeah, so you are correct. When AMRTC deems that someone does not meet medical criteria, doesn't mean they discharge to the street. They actually have part of their policies, they can't discharge anyone to the street. So yes, we are then responsible and paying for that daily rate. I would say our case managers are pretty involved in whatever the discharge plan might be for that individual. But again, the people that are going to AMRTC are the sickest of the sick and can be very, very difficult to place in community placements. So whether that's like a group home setting, a step-down setting like a community behavioral health hospital, they can be very hard to place. Again, a lot of them also have criminal charges, including like assaults, criminal sexual conduct. So yeah, they're just very difficult to place.
Does that trigger, so the deeming not like medically,
Yeah,
they don't meet that criteria anymore, does that automatically trigger a reevaluation of their commitment?
Nope.
No.
Does that make sense? Should that happen?
Yes, it is. That is one of the questions I have been asking when individuals are committed and they're placed at AMRTC, and then the medical director says they no longer meet that medical criteria, yet they are still under commitment. That is one of the questions that I've asked and I've brought up on many work groups.
Can I just ask, how do you budget for this? Like if you have one person or 2 people that end up in these facilities and are determined to not meet medical criteria, how do you budget for that?
Well, given this was my first year of budget.
Okay, that's fair. I'll save that question. How's that?
But you're right. 1 or 2 clients, when I did it,
I mean, these are big numbers.
These are hundreds of thousands of dollars. And so for next year, that's why our highest, one of the highest priority lists we had for the session was to ask for that clause to not be sunsetted in July, because that will cost all the counties.
I just have one follow-up question for the jail. So we're aware, we've all been watching that the jail is currently taking in border people from other counties. Are they also accessing mental health services? Does that matter if you're a border or a not border?
If somebody's in our custody, we make sure we take care of them
Okay.
while they're here. So yes, they do have access. We do see, it's a percentage-wise a much smaller percentage. Usually the counties we're working with to get housed in our jail are sending us fairly stable populations where a lot of our people are coming straight off the street. They're withdrawing from drugs, alcohol, just getting on medication or haven't been on medication if they're seeing somebody. So a jail population tends to be unstable. However, we've been working with the other counties around the state. They've been very good about working with us and trying to provide us as stable population as possible.
Okay. And then just one other question. When we completed the jail study a couple of years ago, one of the things was to look at what are the resources you have for mental health that we could bring into the jail, and I think you spoke really powerfully to that a few minutes ago. We also talked about some training for the jail staff. Can you talk about that? Have you had the opportunity yet to provide training for the jail, or for the COs that are in the jail?
Yes, definitely. That's a big thing. So our officers want that training. Our nurses want that training. They see this as a trend in their career, and they want to be able to be prepared for that. You see, it's really fun to watch a new officer come in and go and work with somebody and talk to them for an hour, and then they come back and they're so excited because they got that person to calm down. I'm in a good place, and they want to know how to do that. They want skills to do that. So, we've been very fortunate that in both providing that at our in-service training and then discussing new ideas for what those trainings can look like, whether it's just education on basic, psychological concepts, or is it trainings on how to talk to somebody.
And that's part of what that embedded social worker can do. I hear that, more formal ones where you probably have maybe hour-longs, but those powerful drop-by conversations that the chief was speaking about, those are in the moment. An officer or can hey, I just saw this. What does that mean? And when they can hear a clinical explanation of that, that really helps them. I think it increases the officer's confidence, which then will help the next time they speak to that person. They might learn some tools and tricks, but I also think it helps them overall feel more confident working with whichever population they come across.
Sure. Thank you. All right, we have time for one more question.
Nothing for me.
Maybe just because we hadn't hit on this, on page 23, the homelessness and disabling conditions, so maybe it looks like over the past year, there was a significant drop. So maybe talk about that. I don't know, since this is only 2 years or so, what it looked like before that. So what were the conditions that there was such a big drop?
Can you say which part you're speaking about? Sorry.
Well, the total households was a big drop, and disabling conditions as well.
I'm not really sure what the drop is due to in terms of individuals, because these are all the households that are on the list, and then the ones who have identified as having a disability, disabling condition. One thing to note is that the serious mental illness is part of that number. So I'm not really sure. Maybe.
I was like, Peter,
right there. Oh.
Hi, I'm Peter Goldstein. I work as a housing unit supervisor here in Scott County. And first and foremost, I'd hold up that the county has made some investments across the housing continuum, right? And so there have been an expansion of programmatic opportunities that seek to really take referrals for this population or for the numbers that we're looking at to try to get them out of homelessness and into housing. So I think that contributes to some of this. We've also made some pretty significant efforts towards list cleanup and trying to ensure that the people that are active on this priority list are having more frequent check-ins. And I think alongside that, right, there are opportunities to get people into treatment programming that might then result in them coming off of the list, or we might find that they were able to self-resolve their experience of homelessness. Now, I think what does hold true in these numbers across the 2-year look-back period here is that the vast majority of people that we're seeing in our community who are experiencing homelessness at the level to be added to this priority list are folks that are reporting that they're living with disabilities or disabling conditions. So that is held pretty constant across this period.
And it looks like the percentage is pretty constant. Like the two data points move in tandem with each other.
Mm-hmm. Great, thank you.
All right, thanks. With that, Mr. Chair, I'll turn it back to you.
Thank you very much. Appreciate that. Colleagues, any questions to start us off? Look online. It's pretty quiet up here. I've got a few questions. Yep.
Mr. Chair, I have a question or a comment. Maybe, I don't know, if Dr. Ward or one of them wants to tackle it. But the graph that Tony brought up at the end is the one that I found very interesting as well. And I'm just curious, between the housing investments, the mental health investments, right, all the work that has been done in schools and co-responders, and I actually think you're holding Canvas more responsible, is my understanding, right, and getting more out of that contract, and maybe you can talk more to that. But the prevention work at the FRC, all of that seems to be showing that trend, right, downward of some of these, and has to be improving even our public safety numbers when you look at those numbers overall, right? It's down. I know the jail is up, but they're not even right? We're helping people out right now. And so all of this together, it's not just one arm of it, but it's all the work you're doing from prevention that seem to be helping in all of these areas, because when you look at your continuum, housing, economics, right? They all play together. So I don't know, maybe talk a little bit about that as well. It seems that the big picture of this work coming together might be showing some positive trends.
I would agree with you. That's a big question. I feel like that could be in itself one of these discussions. I know that, like, we have seen an increase in identifying individuals who have mental illness earlier in the onset, which is really critical. That I think our school-based services do that. The Family Resource Center is doing that. The Coordinated Response Program is doing that. Sometimes those individuals, that's the first time they're going to have any interaction with somebody from mental health. So all of these doors, like I said, they are all access points anywhere on that continuum, and I see that as a very positive aspect. If we can just identify somebody and get them in somehow, that's where we're going to see the best outcome. And I think we've done a good job of changing how that looks and being comfortable with how that looks. It doesn't have to be a four-wall building that people have to walk into. We can go to them. The more outreach we do, the more we're there, we can answer questions. I've seen that. Those are the huge parts. I could ramble, so I'm going to stop there and see if any of my colleagues want to.
Commissioner Brennan.
I just want to thank Chief Tate for being here. I know we've had a lot of conversations before the coordinated response was put into the Shakopee Police Department. And we've had a few conversations since that's happened. So I don't have any tough questions for you today, but I appreciate that you're here.
Thank you.
Not really. So I wanted to follow up. Or Commissioner Beckman-Brecke, do you have any questions before I?
No, I just say ditto to what's been said. I think this has been a great conversation to help us see progress that's been made and identify some gaps and some follow-ups. I do appreciate that continuum that was presented and how many doors there are. And I do think that even that work that's on there is prevention work. So thanks for highlighting that.
Thank you. I wanted to ask a little bit, yes, it's a continuum. We try to have tools that are like super sharp and like do the work and but not every tool is exactly, not designed to fit everything. So that's why you have a continuum. But I think the phrase was eye rolling when it came to Canvas, and not specifically singling out, but sort of signaling, let's talk about that. And I don't know if now is the time, but if there is a tool that people are like, been there, done that, and didn't work or did work, whatever what do we need to do to make, is that something that we need to sharpen, or is that something that makes sense? If it's a tool, we want it to be useful. So again, not necessarily going to get it today. Wait, are you at an auction? You got to be careful because I see an arm going back there.
I think that
was brought up a couple times about some of the workforce challenges that are out there, and I think we see that with Canvas. I think we see that with Guild. We see that with some of our nonprofit providers. And I think we have to pay attention to that and think about, like, how do we help make our mental health system work, even from the nonprofit provider side, because we really, even starting out with the first slide on how do we add more people and bring more people to the table, like what we're doing at the behavioral health clinic. So I think you're asking a really good question, because if something's not working exactly how we would like it to be within our system, we need to go back and reevaluate and try to figure out how to do that. But I think all of our nonprofit community right now is really experiencing some pain when it comes to the workforce piece. And so how do we fix that systemically, not only in Scott County, but across the state?
Well, and also along those lines, I've got so many notes and scribbles on page 3. I'm not even sure where I was going with it, but I do remember. And then kind of referencing page 7, where it says the county has a responsibility to assure a full array of community service for individuals with mental illness. We have this tall task, and then you go back to page 3 where it's like, 0 for the first 30, but, if they're not medically necessary, that's going to change in July. Was it July 1st? I mean, none of this stuff, I feel like a broken record. Like, none of this stuff is sustainable. So, and it's not just our cute little adorable county that's dealing with this. There's 86 other ones that are going to be dealing with this. So the problems, the mandates and the statutes keep getting pushed. And we're not even giving you a carrot hardly anymore. It's so we're not the only ones dealing with this. Doesn't necessarily make it right. And how do we best push back uphill? Because we've all been to the Capitol in those different lobbying days, and last year specifically, it was like, well, yeah, and it didn't matter the color, blue or red, or if there's another one, whatever. Mental health, yep, but we're not going to do anything. Then you'd go knock on someone else's door. Yep, mental health. I mean, yep, we got these billions. Yep, we do, but no, can't. No. It's like, huh? So instead of, I'm tired of being tired. So
I'm there with you. I think for us who are in the mental health profession, we recognize that mental health is just as important as physical health, spiritual health, emotional health, social health. And in the last 5 years, now everyone else in the world has recognized that without the infrastructure to support it. And I think that's what we're seeing right now. Now, I hope that there becomes more federal infrastructure, state infrastructure that starts to recognize this, and there's some parity. You don't have to tell us that. Like, we understand that. But I mean, if we think about any field, have you ever seen a field that has skyrocketed in terms of need as high as this? I'm not sure. And then the demands, and then the cost, and no infrastructure.
Well, and that's exactly it. You are the subject matter experts. You have peers elsewhere, and that's where we need to figure out a way to come together and make sure we're doing a collective push. And sometimes that means, we can't all get what we want, but if we're at least getting majority of what we want is electeds pushing on other electeds, that's, until we get to that point, it's just, we can get upset and be bummed and, this is such a bummer. But no, this is not sustainable, so we got to figure it out. So whatever help with you and your peers to help us and with our peers, like, we need to get this thing together.
Well, I think the support with the CCBHC will be from the board and from the county will be tremendously helpful in that. Now, that won't solve the graph on page 3 problem, but hopefully it might help folks not getting to the page 3 graph, those higher end services.
Right, exactly, because it's.
I think, again, it's that prevention, right? And it's the holistic model. So you have a physical nurse as part of that. You have housing that's coordinated with it. It gets back to those foundational things. So when you're working with the legislature, Commissioner, I still think the prevention and trying to get up front, when she mentioned all these different portals that weren't traditionally ways to access the system, that's helping.
Yeah,
housing investments are helping. I mean, Peter's made a huge difference. I've heard it during the DWM, and it's Peter's coordination of them. It's the investments you've made in disability housing and in family housing and other things that help the reentry housing. You have 8 men who unstable, probably have some mental health issues along the way. That provides opportunities, right? And so those investments in totality are what make it work.
I agree. I do think collectively that we are, our little group, we're doing a lot what we can. We wanted to make legacy decisions with some of that one-time money. Feels like that is happening. I would love to see, just as a barometer, not as a the end all be all, but how other counties look at some of those areas, and not to prove or disprove, but to strengthen what we think we already know to be true with what we're doing, and just to see if those trend lines tend to, I guess, in a way, prove that out. Just strengthens our position in what we're trying to do. Before we end this, I want to see if, just since we're online, if you have Commissioner Weckman-Brecky any last, it's easy to miss you on the video.
You
I mean,
know,
we can never miss you, but I want to make sure that miss a raised hand or something on the screen.
Yeah. No, I miss all of you. I just want to comment on something you said, Commissioner Beer, about changes, and especially with like the cost share for state hospital and things like that. I do think you're right about we need to collaborate with our colleagues around the state. And some of the problem with going to the legislature last year and talking about mental health, everybody did that. And everybody talked about the 100 different things we're doing, or all the things on this page 4 right now. And I do think if we want the state to not pass on any share of that cost when people are at the state hospital, we just all need to go there, and that's what we have to ask for. Some of our problem is we are all over the board, and your question about budgeting or Chris's question about budgeting was right on, because if we're not budgeting for that county cost share, we can use that money for those prevention activities that we know are working, and actually start to see if we're having any true difference. But if we got to keep $1 million in a bucket to pay the state hospital for our folks who are there, it's hard to do that. So those would be my closing comments and my challenge to all of us.
I have one last question before we go, but before I ask that, is there any other? Good. This is a heavy topic, a really big deal, so we're going to end it kind of on a light note. I mean, nothing really. The question for the panel is, if any of you, and this is really not a big deal, sorry. It's going to sound like a big deal. It's not a big deal. But it's a really big deal. If any of you on the panel has a birthday today, please stand up. If you want to.
I'll just stay here.
Okay. Happy birthday. Happy birthday.
Happy birthday.
Okay. Thank you very much. Appreciate your time and all your good work.